Hello, good evening, everyone. I am Dr. Hina Singla, Program Unit of Vision 2020 India, based in New Delhi. On behalf of Vision 2020 India, I welcome you to this webinar come panel discussion on diabetes and diabetic retinopathy, awareness, early diagnosis, treatment, and prevention. Let me introduce our resource persons. Our first expert is Dr. Rajesh Khattavar. He is a professor, Department of Endocrinology and Metabolism, is a well-known academician and researcher in AIMS New Delhi since 2003. Our next speaker is Dr. Alok Sen, Medical Superintendent and Head of Department Vitreoretinal and Uveitis, SNC Chitrakoot. Third expert is Dr. Manisha Agarwal, Director of Vitreoretinal and Clinical Research Services, Dr. Shroff Charity Eye Hospital. Our fourth expert is Dr. Chetra Jaydev, Senior Consultant in Vitreoretinal Services, Narayan Netralia. The event will be coordinated by Dr. Praveen Vashisht. Dr. Praveen Vishy, he is currently a secretary on the board of Vision 2020 and represent head of Department of Community Ophthalmology in RP Center AIMS. I would also like to thank I would also like to thank our CyberSite team for providing us a CyberSite platform, our corporate advisory board members, Appaswamy Associate, Essilor Luxottica, Forest, Microflow. Special thanks to Roche for providing us support for the webinar. Over to you, sir, Dr. Rajesh.
Okay, friends, good afternoon. So today what we are discussing primarily is about type 2 diabetes. Can we prevent it? Or I'm not using terminology reversal, but I'm just using terminology which is more widely used is can it be prevented? So starting with these words, geographical map, everybody of us have seen in our 5th or 6th standards. The country each country is given area in terms of land they are having. So this is our country. If we replace this area of country by the number of diabetes cases, then how it will look like? This will look like the current map. You see the size of India has increased tremendously, size of China has increased, Africa has gone down, Australia is altogether different, and this essentially shows that number of cases these two countries, India and China, we are having. And if we replace the expenditure which is made by all countries for management of diabetes, our country again shrinks back. Not only our countries, other countries shrinks back, and majority of 80% of the amount of money which is spent for management of diabetes comes from either United States or West European countries. So this is one of the limitation factor for controlling diabetes in most of the developing countries. So we have a great challenge. These are a few articles published in the common newspaper. We must have seen all of these. So sometimes we become capital of the world diabetes, or sometimes China becomes, but both of our countries share the maximum number of cases of diabetes. Just share a presentation of our population as well. So just to show you some facts that every 10 seconds a person dies from the diabetes. My slides are moving.
No, sir. It is the India or
No.
China slide. Now it is moving. Yeah.
Now it's moving,
Yeah.
sir.
So every 10 seconds a person dies from diabetes, and every 10 seconds two people develop diabetes. And still the 80% of the cases of diabetes can be prevented by adopting a healthy diet and increasing physical activity. So 80% of the cases of type 2 diabetes can be easily prevented if we adopt a healthy lifestyle. And the South Asians, we have a high prevalence, not only India, but the same high prevalence is also shared by Bangladesh, Pakistan, Malaysia, Indonesia, Nepal. All these countries we share high prevalence of diabetes, and not only diabetes, and high rate of conversion from pre-diabetes to diabetes. And important preventive step, as we discussed, increased physical activity and dietary modification. So when we say that person has developed diabetes, just to refresh our knowledge, because there are some recent changes in cutoffs which we use for that. So the green portion represents the normal blood glucose. If we are taking fasting blood glucose, any value less than 100 milligram percent is normal. or if we are taking 2 hours plasma glucose after oral glucose tolerance test, it's less than 140 is normal. Or if we are using glycosylate hemoglobin, or what we call as HbA1c, if it's less than 7%, this is normal. But any value which is fasting blood glucose 126 or more, it's diabetes. 2 hours plasma glucose after oral glucose tolerance test 200 or more is diabetes, and HbA1c 6.5% or more comes under category of diabetes. So that leaves an important category, yellow one, which is in between these two values, which shows that we are not in normal range, but still we have not reached in diabetes range. So we are intermediate zone, and this zone is called pre-diabetes. So if you are fasting blood glucose between 100 to 126, or 2 hour plasma glucose on OGTT between 140 to 200, or HbA1c between 5.7 to 6.5%, pre-diabetes. This gives us a window of intervention where we can intervene and we can prevent the progression of the diabetes. So how common is prevalence of diabetes and pre-diabetes? So I'm just representing data from the CARS study. This was the one of the largest study we have done in our country, where our department was also part of that, and we found that in red lines you are seeing diabetes, and blue one you are seeing IGTT. So what you are seeing is there is a progressive increase in red lines till the age of 65 years, because more than that we do not have data. Our cutoff was 65. But for pre-diabetes, there is a progressive increase after reaching age of 35 to 45. It does not increases further. So that shows that more cases from pre-diabetes are getting converted into the diabetes. These are the comparative study of two cities, metro cities from India, Chennai and Delhi. So what are risk factors which are associated with diabetes and pre-diabetes coming out from our study? The risk factors are common both for pre-diabetes as well as diabetes. As age increases, risk of diabetes or pre-diabetes increases. If there is family history of diabetes, there are more chances that person can get diabetes. If there is generalized or abdominal obesity, both of them are associated with higher risk of developing diabetes. If body fat, although obesity represent body fat, or body fat is measured separately by the DEXA or bioelectric impedance method, the higher percentage of body fat also favors uh, conversion from pre-diabetes to diabetes. Or if there is dyslipidemia, that is also supportive of risk factor for pre-diabetes and diabetes. This is another study, ICMR in DIAB, famous study which was done by ICMR, conducted all over the country in all states, which again shows that there is, with the as age increases, there is increased prevalence of diabetes both in men and women, although much higher in urban areas, which is shown by the red line, and which is the green one is for rural area. So more common in urban area, more common in men, and as age progresses, the prevalence of diabetes increases. So what happens to all those who are having pre-diabetes? Pre-diabetes, they are absolutely asymptomatic at this stage. So half of these pre-diabetes, if we don't do anything, if we do not give them advice, half of them will continue in same state, while one-fourth of these patients can regress back to normal glucose tolerance. But the major risk comes from the fact that 25% of all pre-diabetes, they progresses to frank diabetes. So this is the window of opportunity which we can use, and we can prevent these conversion from pre-diabetes to diabetes. Although management of pre-diabetes is essentially more or less similar to the management of diabetes, drugs are not required. It's can be used for primary prevention of diabetes or primordial prevention of diabetes complication. Primordial prevention means genesis can be stopped altogether if we can prevent the conversion of pre-diabetes to diabetes. So can diabetes be prevented? When we say that it's a lifestyle disease, means if you modify our lifestyle, it can be prevented. So what evidence is available for prevention of diabetes? So but there are a lot of studies, but I'm just quoting few studies, and these studies have clearly shown whether diabetes can be prevented or not just by lifestyle modification. Although there are studies with pharmacological agents like metformin, acarbose, troglytatone. These agents have been used for prevention of diabetes or preventing conversion of pre-diabetes to diabetes, but essentially it revolves around lifestyle modification. So this is one of the oldest study, famous Dark King Chinese study. This was the first study which was started in 1986. Over 1 lakh subject with screened, and out of which 577 were found to have impaired glucose tolerance. So at that time, term pre-diabetes was not used, and all those IGT patients comes under pre-diabetes. So they were randomized into 4 group: control group with the standard management, then one group went with diet only, second group exercise only, and third group had instructions on diet and exercise. So these are the baseline data, and every 2 years they were examined, and final follow-up were done after 6 years of intervention. So what intervention they did was the advised exercise. So mild exercise for 30 minutes, moderate 20 minutes, strenuous 10 minutes, and very strenuous exercise 5 minutes. And accordingly they also give dietary advice. If BMI less than 25, then 25 to 30 calories were given, and if BFI is more than 25, then they are encouraged to go for a weight loss 0.5 to 1 kg per month till they achieve the BMI of 23 kg per meter square. So you can see this is control group, and all other groups after 6 years there is a marked decrease in the prevalence of diabetes. So control group, the prevalence of diabetes cumulative incidence over 6 years was 67%. But in diet, exercise, and diet plus exercise, all three groups same, but there is significant reduction in the incidence of diabetes. Another study, diabetes prevention program carried out in US, published in New England Journal of Medicine, where around 3,000 non-diabetic person or pre-diabetes person were randomized to receive placebo, metformin, or lifestyle modification, and with different goals, about 7% weight loss and 150 minutes of physical activity per week. And what they have shown that in comparison to the placebo, there is 31% reduction in uh, diabetes incidence when metformin was used, but much higher than that, intensive lifestyle intervention led to 58% reduction in incidence of diabetes. Means pre-diabetic subjects were prevented to convert into diabetes just by lifestyle modification, which is much more effective if we use drug like metformin. Another study, Finnish diabetes prevention group, similar inclusion and exclusion criteria in the age group of 40 to 65 years, and they have also shown that lifestyle modification again lead to 58% reduction in the incidence of diabetes. So all these three studies clearly show that if we intervene at the time of pre-diabetes, conversion to diabetes can be prevented. And is this applicable to our country also? Because we have little bit differences from the other countries. We have higher risk of we have higher incidence of insulin resistance, less physical activity. So the IDPP is Indian Diabetes Prevention Program, which was published in 2016. And what in this study was done, there were 4 groups: control, lifestyle modification, metformin, then lifestyle modification and metformin group. And intervention was lifestyle modification, brisk walk for 30 minutes daily. Metformin group received 250 milligram twice a day. And then there was third group of lifestyle modification plus metformin. And these interventions were done for a period of 3 years with 6 monthly follow-up. And in IDPP program also, you can see that in comparison to the green line, which is control line, all other 3 arms clearly show that there is decrease in incidence of diabetes just by lifestyle modification, and there was no difference if you add metformin or not. The incidence decreases mostly because of lifestyle modification. So progression in IDPP highlights where progression of IGT to diabetes is high, as we have seen in control group. Possible to prevent diabetes in Asian Indians. There was no significant change in weight. Even then, there is decreased incidence. Metformin is effective, but lifestyle modification is more effective than metformin in prevention of the diabetes. So, if we conclude from all these studies, diabetes can be prevented effectively, easily, just by lifestyle modification. Drugs can also be used, but they do not provide any additional advantage over lifestyle modification. And I have not shared data, but that effect of this initial intervention is long lasting, and this intervention effect prevent the cardiovascular mortality and microvascular complication even 15 to 20 years after the intervention has ended. So we know that prevention of pre-diabetes to diabetes is easily preventable. What we need to do is high index of suspicion in general population. We should screen for diabetes and pre-diabetes. And if we found that they have diabetes or pre-diabetes, lifestyle modification or management is the first step which we can do in these cases. And what are these lifestyle modification? The 5 healthy behavior goals for diabetes prevention is: keep your BMI less than 25 kg per meter square. Fat intake should be reduced to less than 30% of total energy intake. And saturated fat, out of this 30%, saturated fat should not be more than 10% of energy intake. Fiber intake should be increased to 15 gram per day. And physical activity, which is approximately 4 hours per week, will give you enough protection. And if you follow these 5 steps, most of the cases of prediabetes can be prevented, or prediabetes to diabetes conversion can be easily prevented. So this is suggested physical activity for adults: at least 150 minutes of moderate intensity aerobic exercise throughout the week, or at least 75-minute vigorous intensity physical activity spread throughout a week, or at least 5 days in a week. Or if you are doing aerobic exercise, just 10 minutes duration bouts every day, you can prevent diabetes by doing these physical activities. Lifestyle modification with your BMI more than 25 kg per meter square. Initial target is lose 1 to 2 kg per month, with long-term gain of long-term goal of weight loss is approximately 7% of body weight. So if somebody loses 7%, beyond that, the further weight loss will give you only cosmetic advantages. All medical advantages which we can get with weight loss is achieved by approximately 7% weight loss by intense physical activity. And limit your caloric intake to 500 by 1000 calories, reduce dietary fat, uh, limit intake of SSB or sugar sweetened beverages. Dietary fiber should be increased to approximately 14 gram per day. So who should be screened? Anybody who is having family history of diabetes should be screened, or starts at the age of 45 years. If normal, every 3 yearly should be repeated. If there are more risk factors like obesity, hypertension, physical inactivity, family history, central obesity, smoking, then this can be started early, even can be started at 35. If risk factors are there, we can do more frequently. Fasting plasma glucose is recommended screening test. OGTT gives best result, but little bit cumbersome in the public health setting. And once it's confirmed, the evaluation should be done in public care setting. And these are the, once diagnosed, these are the various options, medical options. If it's not controlled with the diet and exercise or lifestyle modification, we can use these medications. And what is being done at the level of government has started 2 large national programs: national program for prevention and control of cancer, diabetes, cardiovascular disease and stroke, NPCDCS. So this was started in 2010 with the focus on strengthening infrastructure, human resource and development. Till now, 2.11 million individual has been screened, and confirmed diabetes prevalence has been 4 to 4.46%. And similarly, national guidelines for diagnosis and management of gestational diabetes has also been started. Right now, this has been started only in 2 states, but with the government planning to spread over all over the country. So this is what I wanted to communicate regarding the prevention of diabetes. Thank you very much for your hearing, and if there are any questions, would be happy to answer.
So thank you, Vision 2020 and Dr. Praveen for giving me this opportunity to speak on this important topic of policy frameworks and institutional initiatives in diabetic eye care. I think Dr. Rajesh has beautifully highlighted the immense problem of diabetes, which is emerging worldwide. And we have a humongous number of diabetics all over the world. India is no different. And in the last census, it was declared that we have about 101 million diabetics who are residing in our country. There has been an ICMR study which has shown that not only the diabetics, but also the number of pre-diabetics are on the rise. And we have an equal number or even more number of the pre-diabetics who one day are going to become a frank diabetic, as already highlighted by Dr. Rajesh. So there is a changing prevalence of diabetes, and it is not just restricted to metropolitan cities or larger cities, but we would realize that it is spreading to the rural parts of our country. And that is a major concern because we know that the kind of access to medical care is far better in the larger cities in comparison to the rural parts of our country. And thus, we are ignoring this burning problem of diabetes, which is emerging in the rural parts as well. Dr. Praveen is there and he's done a beautiful RAP study. And he was kind enough to share these slides with me, which highlights some very important key features regarding diabetic retinopathy. So in our country, by this RAP study, the prevalence of diabetic retinopathy came out to be as high as 17%, which is extremely high. But what is interesting to know is that about 90% of the diabetics had never had an eye examination. Now, that is a major concern. That means either there is no access or there is a lack of awareness of diabetic retinopathy and its associated blindness amidst the majority of the diabetics in our country. And as per their data, the amount of visual impairment secondary to diabetic retinopathy was as high as 14%, which again is very high. So the major findings from this survey was that the prevalence of diabetic retinopathy was as high as 17%, but the vision-threatening diabetic retinopathy was 4%, and that means about 3 million people or 3 million diabetics who are residing in our country are actually already having a vision-threatening diabetic retinopathy. Diabetic retinopathy is responsible for about 1.2% blindness, and keeping in mind the large population of our country, that again is a very huge figure. The current study also highlighted the critical need for the coordinated and multi-sectoral approach to reduce the prevalence of diabetes and for the onset of diabetic retinopathy. This was another study where 25 centers apparently had participated, and Shroff Charity was also a part of it. Dr. Alok, who's a part of the panel, again was a part of it, and this was the Smart India study. And this study again had included both rural and the metropolitan city populations for screening for diabetic retinopathy. And I would just like to highlight a few key findings. As I mentioned, the vision-threatening diabetic retinopathy, that means the diabetics who are already at that stage that they are about to be losing their vision secondary to diabetic retinopathy, is as high as 3 million in our country. And this study also proposed that it would be a good idea because we have limited resources in our country and we possibly cannot consume those resources just for screening each and every diabetic for diabetic retinopathy. Therefore, it was imperative that we actually focused on those patients who were having VTDR and at least had some system in place where we could screen them and manage these patients on time before they became permanently blind. So this study highlighted the very important fact that both urban and rural areas, they needed attention. and there had to be certain policies in place where both rural and urban populations were well taken care of, and they were screened on time for diabetic retinopathy, and also they were managed on time to prevent blindness. DR screening efforts should be more for people who are with known diabetics because, as I mentioned, the resources are limited in our country. And if we were to start screening each and every diabetic, probably the resources are not going to be enough to screen all of them. Now, if we limit the screening of the patients or the screening of the diabetics only to the ophthalmologist, I think the number is going to be too short. Therefore, it is important in today's time that the physicians are also trained how to be doing a DR screening in their clinics because they are the first point of contact for any diabetic. And if they themselves are not trained, in today's time, we have some wonderful AI-based fundus cameras, which are non-mydriatic cameras, which can be beautifully used in their clinics to actually screen each and every diabetic who's walking into their clinic for the management of diabetes. Now, these are the other aspects, but even the lack of awareness in our population of diabetics is a very major factor because of which they actually don't access whatever medical care or resources are available. And like the RAP study of Dr. Praveen, which showed that 90% of the patients who had diabetes had actually never undergone examination of their retina. Now, if we were to see the statistics in our country, we have about 3,500 trained retina specialists. We have about 35,000 ophthalmologists in our country. However, we are talking in millions in our country of diabetics who are there. We are talking of 3 million people who are having vision-threatening diabetic retinopathy. So probably the resources which are available in the form of skilled retina specialists is too less to cater to all these number of patients who are having a vision-threatening diabetic retinopathy. So probably these retina specialists have to focus on the management aspect of diabetic retinopathy, and we have to increase our manpower to be pitching into screening for diabetic retinopathy. Now, if we have only 20% of the diabetics who are suffering from DR, we are saying that 20% of these would have about vision-threatening DR. And since we do not know that which 20% will actually be requiring the examination, we probably will have to screen all the diabetics. And therefore, we have to understand that it has to be an opportunistic screening without having missing any opportunity. It has to be everywhere and every time a diabetic comes to us that the screening for DR has to be done. As far as the initiatives by various institutes is concerned, various screening models have been created. You can have DR screening camps where we all have seen that they have not been very successful because most of these camps are perceived as eye screening camps and majority of the patients just have cataracts. A lot of patients who are non-diabetic also come for these camps. Then you can be using an opportunistic DR screening in general physician clinics, pharmacies, pathology labs where these AI-based fundus cameras can be used. You can be using these mobile van units. A lot of institutes are using, like Shankar Netral is using a mobile van unit for doing a DR screening. And a lot of institutes like Arvind Eye Hospital, I'm aware of, are using the tele-screening where the turnaround time is about 1 hour. But if you are using an AI-based camera, then the turnaround time for getting the report is as small or as short as 1 minute. So the unmet needs for inclusion of retinal diseases, including diabetic retinopathy, I think WHO, it starts right from WHO, who is having a separate area dedicated for chronic diseases. But you'll be surprised to know that this area of WHO also is not including retinal diseases, and in specific, the diabetic retinopathy is not included. NPCB also majorly has focused on the cataract blindness, and probably that has resulted in a major reduction of blindness due to cataract. But probably there is nothing as of now included in NPCB to be focusing on blindness secondary to diabetic retinopathy. So if we were to talk of the current scenario of the national policies, there's no national program for control of blindness due to diabetic retinopathy. There's no policy in place to include DR screening at levels of primary health care or district hospitals. The NPCB is just giving a 2,000 rupees for management of DR, but there is no other facility available for DR screening or for DR management. And if we were to talk of the Ayushman Bharat, it has included DR screening. But what is important for us to realize is that there is uh, uh, prerequisite for DR screening is that the OCT is mandatory, and therefore the physicians are not able to take advantage of this because they are not having an OCT machine in their clinic. So probably this needs to be modified. Now, if I was to talk of what should be really done, well, we have to improve the awareness amongst all the stakeholders. The screening for DR has to be not limited to ophthalmologists and to retina specialists. We have to find alternative sources, such as the physicians have to start pitching into screening for DR. We have to start screening in the community. We have to use technology in the form of AI-based cameras. We have to improve primary care for diabetes so that there can be a prevention for the onset of diabetic retinopathy. And there has to be steps taken at all the levels. As far as the policy and system level enablers to strengthen the retinal health is concerned, there has to be integration into the national health programs like NPCB, the Ayushman Bharat, and the NHM, and they have to start focusing on the retinal diseases and the blindness associated with them, especially on diabetic retinopathy. Capacity building has to be there, especially in the public sector providers, and all the people like the general ophthalmologists, the optometrists, the ANMs, they all have to be given training for the basic retinal examination and referral protocols for diabetic retinopathy. Training of the general ophthalmologists, the national societies like VRSI and AIOS, they have to start pitching into it. Not only training all the ophthalmologists for screening of DR, but also training them for early on management like laser photocoagulation and for giving intravitreal injections. There surely needs to be a decentralization of screening services by using these portable fundus cameras, community to hospital referrals. As far as the cost is involved, it is an expensive treatment, so we have to start talking to the Ayushman Bharat and NHA that they have to include certain more facilities for managing these patients with diabetic retinopathy, like the VRSI is really pursuing Ayushman Bharat to include intravitreal injections coverage. The support low-income patients through public, private, and non-profit partnerships. So I would just conclude by saying that diabetic retinopathy is surely a major public health problem in India today. There are socio-demographic differences. An effort has to be made to improve the public awareness. There is a need for active screening programs, especially for diabetic retinopathy. However, the need of the hour is to surely have a national program for the control of blindness due to diabetic retinopathy. As far as a brief roadmap is concerned, we have to work on spreading more public awareness where the patient himself starts demanding that I need a retinal examination being a diabetic. Training at all the levels, all sectors of the medical service providers have to be trained for a basic retinal examination. An opportunistic screening for DR has to be done, whether it's a physician clinic, pathology labs, chemists, or district hospitals or primary healthcare services. We have to increase access to retinal care services. We have to have prevention strategies for DR and other retinal diseases. And surely this cannot be successful if the medical care is not made more affordable at all the levels. So thank you so much for your patient listening.
So I am Dr. Alok, and I'm from probably one of the eye centers, large eye centers, which is predominantly working in a rural area. So, and so this map, which has been shown already by two of our speakers, and it just reinforces that how important is the focus on diabetes and diabetes related complications that is to us, as we have probably the largest number of diabetes mellitus. Not only that, we have a huge number of patients with diabetic retinopathy, and already we have patients who have vision threatening diabetic retinopathy and who need immediate attention from our side. So we have a burden which is beyond our capacity to deal with already. And most of it is because of the delayed presentation. And we did a small study in our center because we used to get a lot of patients with sight-threatening diabetic retinopathy or advanced diabetic eye disease. And what we noticed, apart from lack of awareness and the patient did not have visual symptoms, so they didn't come. One major outcome was that there was failure of the patients to undergo fundus examination. About 70% of our patients had seen an ophthalmologist before they had come to us, but none had documented fundus examination. So that is one issue that we need to be dealing with. Now, we all know that diabetic retinopathy is a disease that can be prevented by regular and periodic screening. However, even in the best of the centers in the West, about only 60% of the patients, they undergo regular uh, screening process, which is advocated. So in India, we hardly have anything like that. We don't have a systematic screening program in India. What we generally do is we have two sets of screening strategies. One is traditional screening, which is done by the ophthalmologist by doing a dilated fundus examination, but it's really inexpensive and inadequate in a large country like India. The other is, which we are more often doing nowadays, is retinal photography based screening, where the optometrist or the technician is taking the lead. It is an optometrist or technician based program, while ophthalmologist leads it. So there are various models of screening, which Dr. Manisha has already highlighted, of which I just want to highlight the NCD clinics, which have come up in all the district hospitals across India. And these clinics have a registry of for patients with diabetes, and they give us a very good opportunity to do an opportunity screening. And there is a study which was published in IGO by GVS Murthy et al. And they showed that it not only helps in improving the screening of the patients for diabetic retinopathy, but it also, and there was a 50% increase in the follow-up rates among the patients who were screened for diabetic related complication in these clinics. There are other models like community-based, where we do rural outreach programs through our mobile vans or the vision centers. And as highlighted by Dr. Manisha, that these screening programs never give us that kind of outcome as we would expect. However, we are using more and more of tele-ophthalmology, especially post-COVID, and we use a non-mediatic fundus photography for this, which has shown to be more cost-effective than the traditional screening. And it reduces, not only that, it reduces the load to the clinics. Moreover, it helps us get more follow-ups through our vision centers and the peripheral centers. However, the non-mediatic fundus photography-based screening has less sensitivity than, and it has shown to be, the sensitivity has shown to be as low as 70%. Moreover, there are other issues like many of the photographs may be ungradable. And of course, in rural areas, there would be issues of connectivity and internet connectivity and others. So what has come up in rescue is the AI-based screening for that, and it is not only shown to be cost effective, it is the sensitivity is as high as 95%. Moreover, the ophthalmologist nowadays doesn't have to grade the images, because if you know that there is a study which was published and it showed that when an ophthalmologist takes about 12 minutes to grade an image, while the AI can do the same in seconds. So that is an added advantage. So the AI can triage patients for the ophthalmologist which need ophthalmologist attention. So that helps reducing the load from the ophthalmology clinic. So AI can not only help in detection and screening of diabetic retinopathy, but nowadays AI can provide you with staging of diabetic retinopathy. This helps in stratifying patients at high risk, as Dr. Manisha was again mentioning in our presentation, that we need not screen all the patients that regularly. We can modify our screening or personalized screening based on the risk stratification. The AI can also help in monitoring and predicting the treatment response, which is important integral part of any screening program. So to conclude, optimizing screening is very important in identifying diabetic retinopathy early and to prevent sight-threatening disease. What we need to do is to improve the awareness among, especially in the rural area where the awareness about diabetic retinopathy is not there. Boost infrastructure, maximize the use of technology in this, train the human resources, integrate. The most important is to integrate referral and treatment services along with screening, because without that, any screening program will fail. And thank you so much. I think I have finished in time, and I will be happy to answer any questions.
Thank you so much.
Thank you, Dr. Hina, and thank you, Dr. Vashish, for this opportunity. Very glad to be part of this panel. And after some very important topics, I'm going to conclude the talks with what contemporary evidence that we have for the diagnostic and treatment modalities for diabetic retinopathy. The importance of the problem has already been emphasized very, very strongly, which means we have a problem and we now need to see how we can handle it with the best possible outcome for our patients. So this is a normal retina for those of you, who are not ophthalmologists and in the audience. So this is the right eye retina, where actually it's the only organ where the blood vessels can be seen directly. As you can see here, you can see these red lines, they're all blood vessels, either arteries or veins. So only organ without doing anything, and just with a photograph, you can see the retina. Now, this is the retina of a patient with diabetic retinopathy or proliferative diabetic retinopathy. You can see how grotesque a picture it is and how scary it is. And these are all young diabetics in the working age group between 30 and 50 years of age. And it's not just one eye, both the eyes are affected, both the retinae look like this. There's a lot of proliferation here. The retina is all crumpled up, and you can see those red lines that I showed you have all become white. A lot of them have become white. It indicates that there is no perfusion or no blood flow, which means the tissue is not functioning adequately. So we do have a huge burden of diabetic retinopathy with more than 100 million people affected worldwide, and 5% of them have a risk of going completely blind, which means these patients will not be able to recover vision in both eyes if they're not treated adequately, which means their productive age group and their career is completely gone. So it is a leading cause of vision loss, and we have stages from non-proliferative diabetic retinopathy to sight-threatening proliferative stages. We have an urgent need for treatment in our community, which can balance the efficacy, safety, and reduce the patient burden. Why is it a burden? Is because it's a recurrent treatment. Yes, diabetes is a lifelong disease, but most of the diabetics can be managed with either injections or with tablets. But what about the complications? Well, with renal complications, they do need dialysis, which is again very costly. And with retinal conditions, they need injections either monthly or 2 monthly or 3 monthly, which becomes a very, very huge burden on the system and on the patient and the caregiver as well. So before actually figuring out whether the patient needs treatment or not, you have to see the different diagnostic approaches. They help us make decisions for treatment, for follow-up, and we also want to know the response to treatment. So imaging has become indispensable. Some of the most common imaging modalities that we have are color fundus imaging, which Dr. Alok already spoke about. We have angiographies, we have OCT, we have something called as an OCT angiography, which is a non-invasive test to look at the vasculature, and the B-scan, which is an ultrasound device where the view of the retina is not there, but we can still figure out what's going on in the posterior segment of the eye. So these are some of the color images which are showing you how advanced the disease is. You can see retinal folds, you can see bleeding in front of the retina, you can see an entire flower-like structure on the left top, which is basically neovascularization at the disc. So these are all advanced images of patients with diabetic retinopathy. So these are again wide field images around 50 to 70 degrees, where you can see the preoperative fundus image with a lot of, again, retinal folds. You see, we call them tractional bands as well. You can see hemorrhage there, and you can see a lot of neovascularization on new blood vessels, and this is post-surgery. So these imaging tools become a very important educative medium to explain to the patient as to what happens, because you can't see from the external, right? You can't tell that there's something so bad going on inside the eye, because externally the eye looks absolutely normal. And these have now again really changed how we manage our patients. These are wide field fundus imaging, not just at the posterior pole, you can also see in the periphery or in the side of the retina. Indians have a lot of predominantly peripheral diabetic retinopathy. So this definitely helps patients in, for us in picking up those patients who have peripheral diabetic retinopathy and following up more closely. So this is a wide field angiography. I spoke about new blood vessels. So wherever the dye is leaking, it shows up like this and indicates that they are new blood vessels and they need laser treatment. This is an OCT. This has more or less part of our day-to-day practice as far as treating diabetic macular edema goes. These are the two eyes of a single patient, and after injection, you can see the response to treatment is fantastic in one eye and actually not great in the other eye at all. So this is the one that I was talking about, Octa. Even without a dye, you can see the neovascularization beautifully. And more importantly, you're able to delineate it very well, because once you give the dye, there's a lot of leakage and you can't see the blood vessels so well. Last thing is the B-scan ultrasonography when there is no view, either because of a bleed or because of a dense cataract. Here you can see the bleeding there that is moving around as white dots. That's all hemorrhage or bleed that is there in the vitreous. And this is something called as a tractional retinal detachment. You can see a thick white band. That means the retina has got detached and this patient potentially needs surgery. Now, that's in brief about diagnostics. Let me cover also treatment strategies. I'm not going too much into the detail. Well, the gold standard initially, at least for the last 50 years, had been laser photocoagulation and also focal or grid laser. But as the years started going, at least for diabetic macular edema, we started getting more options. The mechanism of action is it basically destroys the ischemic retinal tissue so that the neovascular stimulus to produce these new blood vessels, to cause edema, the VEGF production basically is reduced here. We do have a lot of newer laser photocoagulation techniques such as targeted, and we have micropulse. So this will definitely minimize the collateral damage. But the main disadvantages is that it may at best preserve the vision. It will not really improve vision, can cause peripheral field loss, reduce night vision, and sometimes even scarring, which can actually make the vision even worse sometimes. Well, anti-VEGF therapy or intravitreal therapy, we have steroids, we have anti-VEGF that has revolutionized management of diabetic macular edema and even PDR for some patients. So here again, what it does is it blocks the vascular endothelial growth factor, secondary to which there is reduced leakage and neovascularization or new blood vessels formation. This has now become the gold standard for management of diabetic macular edema. Well, there are treatment challenges here. Like I said, it's needed either monthly or 2 or 3 monthly, and it has to be preferably given in an OT. And there are risks of infection, bleeding. So these are again some of the challenges. But ever since it was been introduced literally 20 years ago, it has definitely offered better visual acuity or visual improvement in patients receiving treatment. Now, to overcome that monthly, there are some of these new innovations which are implants. So this was approved in May 2025, and it only needs to be given every 9 months. So even the trials have shown good outcomes and even reduction in the severity of the diabetic retinopathy. So since this is a continuous drug delivery system, it will definitely be patient friendly for long-term management of diabetic macular edema and diabetic retinopathy. And few other emerging therapies that we have available are TKI or tyrosine kinase inhibitors. There are two drugs undergoing trials, phase 2 and phase 1, and both of them seem to show that there are good safety profile with minimal inflammation, but we are still awaiting long-term results. And then there's gene therapy. It's the flavor of the season. Every disease we are exploring options of gene therapy. It's obviously a one-time treatment, so it will definitely help our patients. This is one of the potential targets here. So basically what happens is that it produces sustained anti-VEGF expression. So that means you don't have to keep giving anti-VEGF drugs. It will be expressed directly within the retinal tissue. So eventually the aim is to reduce or completely eliminate the need for repeated intravitreal treatments. There are several trials going on, and we are waiting for this because it will be a single treatment that can address all these patients who have a risk for blindness. And then there are a few other approaches like anti-inflammatory, nanotechnology, regenerative medicine, and AI-guided treatment that again, I think that Dr. Alok spoke about. It's not only for diagnostics, but also for AI guided, wherein it will predict, when probably the next injection is required, whether this patient will respond or not. Those will be really fantastic for all our patients. So to conclude, we need to integrate all these treatments and offer our patients personalized strategies, because one patient is different from another. One could have hyperlipidemia, one could have been end-stage renal disease. So there is no one size fits all. There could be a combination therapy, definitely a tailored approach for each patient. And we do have so much of evidence coming in that we have alternative approaches as well. because the future of diabetic retinopathy care lies in precision medicine, because we want to save our resources to give the best for our patient, we should be able to optimize clinical outcomes through individual treatment strategies. Thank you so much.
Thank you, Dr. Chetra, for an insightful session. Now, I would like to request Dr. Praveen Vishesh, Secretary of Vision 2020, to go for
Thank you.
panel discussion with our four experts. Over to
Thank
you,
you.
sir.
Thank you, Dr. Hina. In fact, all the speakers have, I believe, very clearly covered most of the questions, most of the topics which I was thinking in my mind. I'm really thankful to all the speakers for comprehensively covering this entire topic. But I have some few questions. I think I'll take one by one. If then I can request Professor Rajesh Khargawat. Sir, are you there?
Yeah,
Yeah,
I'm
yes,
here.
sir, sure. See, in fact, in your talk, we have like a very clear understanding about diabetes and pre-diabetics, their levels, the risk factors for diabetes and pre-diabetes. That is fantastically covered. One question which is always there in my mind, and a lot of advertisements are there. Can we reverse diabetes? The diabetes reversal program. And people are like giving some equipment which have a continuous sugar monitoring. So what is your say about those things, sir? Are these good programs? Should we go ahead for these things? We need this expert opinion on this.
Yes,
Mm,
Dr. Praveen,
mm,
yes, very
mm,
important, and it's a burning topic, like can diabetes be reversed?
mm.
Type 1 diabetes, there is no question, it cannot be reversed, we cannot think of. For type 2 diabetes, reversal is almost impossible.
Okay.
It can be controlled, it can be controlled with lifestyle modification. You
Mm,
follow diet and exercise, and
mm,
your blood glucose will be controlled. Your HbA1c will maybe less than 6% or less than 7%.
mm,
But it's not possible. It will never happen that you eat lot of sweets and next day your blood glucose remains normal. If you
mhm,
are in pre-diabetes, if you are
mhm,
not taking care of diet and exercise, yes, it will come again. But it can be adequately controlled. Some reversal has happened with the bariatric surgery. So after bariatric surgery, because large amount of fat is also reduced from the body, and the absorption of carbohydrate is also affected. So in that case, if your HbA1c remains in the normal range for a period of 1 year from the date of surgery, in that
mm.
case, it can be called reversal. Otherwise, it's not reversal. It's controlled lifestyle modification. Second question was like continuous glucose monitoring system. Yes,
Yeah.
continuous glucose monitoring system is good system. It measures the tissue glucose, not the blood glucose,
Mm,
and this is usually what we use is for type 1 diabetes. For type 2 diabetes, this is not advisable to use this system, because that much frequent monitoring we do not require, and there are hardly any advantage if we use in type 2 diabetes. In type 1 diabetes, or there may be situations in type 2 diabetes, like somebody is pregnant and diabetic, in that case we can use, or it's a labile diabetes we can use, or in spite of our best efforts, if we are not able to control diabetes, yes, it may help in this. But otherwise, this system is at present is devised, approved, and in clinical use for type 1 diabetes.
thank you, sir. Another question from program point of view, which I have always been observing, that even country we know diabetes is almost an epidemic now. Still, nearly 65 people are actually aware of their diabetes status. 35% of diabetic people, they are not even aware of their diabetes status. In fact, what we have observed in our eye clinic, we are identifying diabetic retinopathy, and only then patient is coming to know that he is diabetic also.
Yes, yes.
Is there any chance from the national, because you are representing AIMS, which collaborate with Government of India also in national program, for better screening for diabetes and referral for diabetes for higher centers? Is there any modalities for this, suggestions on this, sir?
Yes, definitely. And whatever data you have suggested, I would say that for every type, 30 diabetics, there would be 60 undetected in the population. The number of those who are undetected in population is number 2. So we have to screen more and more patients. These are the risk factor. We, with the more collection of data, we may have a few more risk factor, but these are the most important. And if we based on these risk factor, if we start screening, we will be able to diagnose more and more patients.
Thank you. Thank you very much, sir. Thank you. I'll come out.
I think Dr. Alok and Dr. Chetra, they have raised their hands.
Yes.
Yeah, sure, sure. Dr.
Yes.
Alok, please.
So just one curiosity, like there are a lot of sir, devices now available, non-prick devices to measure blood glucose levels, and how good are they for screening purposes if we use it for screening diabetes and diabetic retina? Like, and are there validated devices available in India?
Yes, very good, very important question. So all these devices are not approved. These are not scientifically approved. They have never been scientifically studied for diagnosis of diabetes. So what's use is, in a diabetic patient, if you want to know whether it's a controlled or not, where we do not want a specific cutoff based value, like we do not want 125 or 126. We want blood glucose between maybe 100 to 160. It will make will not affect your decision making. In that case, we can use these devices, but most of these devices are not scientifically proven. They are not FDA approved. Only FDA approved is GlucoWatch. GlucoWatch was available some time back, but because of our country's temperature and humidity, GlucoWatch is not successful in our country. So all other devices are not they are not approved for the use in diabetes.
Thank you so much. So thank you.
Dr. Chetra, please.
Sir, I'm not sure whether I missed your question, this point. There's a big, enthusiasm for GLP-1 now. So what is your take on that, sir? My concern as a retinologist is that it causes worsening of diabetic retinopathy. So since you're talking a lot about lifestyle modification, how does this fit into your, plan for your patients? Is it commonly used or not?
GLP-1 analogs, yes, they are commonly used, and we want to use in each and every patient, provided the patient can afford that. Its only concern is coming from ophthalmologist only because of the retinal changes induced in it. A lot of studies have been done. There are initial data which suggest that it increases the progression. So because of that, there are limitation on that. If you are using GLP-1, then you have to have retinopathy status first known. Yes, these drugs have given a new hope of reducing weight to the extent of 5 to 10% or 5 to 15%, and they are quite successful. And you must be knowing from the all social medias that they are in a huge demand, and all these products are in such a huge demand that their parent company cannot produce that much amount of doses of these GLP-1 analogs. But yes, there are concerns, not only concern coming from ophthalmologists, concerns are also coming from psychiatrists, where suicidal tendencies have been shown to be increased with the use of GLP-1. Although this is preliminary data, more data is sought for a find out a causal relationship with GLP-1 analog. But there is serious concern about use of GLP-1 analog and retinal changes.
Thank you. Thank you, sir. Thank you very much. Thank you. In fact, my question is, Dr. Manisha is there? I think she's not here. In fact, her session was very good from program point of view, and I'm very keen that the National Program for Control of Blindness, she mentioned that at present there is a very little initiative, specifically in terms of indicators related to the diabetic retinopathy. And her suggestion that we should have a regular indicators related to number of people screened for diabetic retinopathy and also number of people treated for diabetic retinopathy. These two indicators are required at national level, and probably we should try our level best as an advocacy measure that these two indicators should be added. It is something very, sorry to say that hardly 10% of the diabetic in country, they are actually getting their retina examination. This is the National Control of Blindness, that survey finding 2019. Just 10% of diabetic, they are getting retina examined. And recently, WHO, CRO, they have come out with one of the indicator that this number should increase to 80%. 80% of diabetic should get their retina examination, and this target has been kept till 2030. We hope that this indicator should also be added as part of the indicator target for the National Program for Control of Blindness. But her talk also covered about various strategies to improve the program, that is awareness, training program, decentralization, integration of various national programs for diabetic retinopathy, and also about cost effectiveness. When I talk about cost effectiveness, then one question directly comes in my mind: how cost effective is treatment for diabetic retinopathy? I think I should request Dr. Chetra, these injections, currently we feel it's a common perception that the injection for anti-VEGF injection for DR, they are very costly, and it is very difficult for a common man to afford these injections. Your suggestion on this, or expert comments?
So initially, Dr. Praveen Vashisht, as you're aware, we had only innovator molecules. In fact, when we first started with these anti-VEGF injections, they used to literally cost a lakh or more. But now, over the past 10 years, we've had biosimilars, and we are the first country in the world to have made a biosimilar for anti-VEGF medications. For the innovator ranibizumab, we have an biosimilar, and that has actually made treatment a lot more affordable for our patients. And we have almost all the new molecules. Very soon, we are having biosimilars even for advanced molecules. So yes, a treatment has become more affordable, but that is still only for those patients who have access to healthcare, who are affordable. What about those patients, in the rural tier 2 cities? The income does not really allow them to be able to take these injections on a regular basis. And we have young patients actually losing central vision, reading vision, because they don't take treatment. And by the time they can arrange for funds and come back, the vision is lost because, even if the edema comes down, the function of the macula is lost. So it's very important that timely treatment is given. Which will help, like you said, to policy decisions wherein including these anti-VEGF or intravitreal therapy is included in part of the, Ayushman Bharat, for example, and that applicability should be there for the entire country. It can't be restricted to certain states or regions. If that happens, and then I think patients will definitely be able to get more access. In fact, we had major challenges with insurance before. Since it was a daycare procedure, many patients were not getting covered through insurance, but now it's a lot better, and we are able to, many of these patients are able to afford treatment.
So you believe that it is feasible that Ayushman Bharat may cover the cost of injections in country, and
Absolutely,
we need
absolutely.
to work as an advocacy measure for to
Yes.
Government of
And
India.
also to push research and development, especially for these biosimilars, which will definitely help not only retina conditions but beyond. So many other conditions. All these anti-inflammatory drugs, all of them will make a huge difference.
What we have observed is most of the time it is a major challenge for a screening program. Dr. Alak, I'll come to you. Just one question from her.
Yes, yes.
Major challenge that we do screening program, but patients are not coming to hospitals after screening. In fact, we also have an experience. We conducted a mega screening program as part of program in AIMS, and hardly 48% of the patient who were actually asked to come to hospital, they are identified with diabetic retinopathy, they reported to base hospital. In spite of that, we were providing free treatment to them. So any take on how to improve this area, this field, that patients should come to hospital if they're screened with diabetes?
So
That,
your health-seeking behavior is not there.
yes.
So the problem with this population is they have myriad other health issues. Their renal failures are there. They have non-healing wounds. They have neuropathy. So somehow these patients, even those who know that they have retinopathy, do not come to the hospital because diabetic retinopathy is not life-threatening. So unlike in nephropathy, where if they don't go for dialysis, they risk losing their life. So also they prefer to keep their resources, their funds for something life-saving than vision saving. Because I have patients who, today a patient walked into my clinic who 6 months back I had advised an injection, a simple injection, which would have cost him probably 10,000. Today, 6 months later, he comes saying that I had a heart attack. I underwent a stent. Hence, I could not come. I was hospitalized. Now, he's come 6 months later with neovascular glaucoma and that eye cannot be salvaged. So what they feel, okay, एक आंख का तो चला गया, दूसरा आंख है. That is the mentality, unfortunately. But what when the other eye gets affected? That's when they realize, the delay has probably cost them the vision for life.
I believe one of the reason is that people feel that at present they can see well, there is no problem because
Yes.
initial stage of DR. And they like in cataract, patient comes when there is a severe visual impairment or visual impairment, only then they report come to hospital. And they have the similar feeling for diabetic retinopathy also, that there will, when vision will be like affected, only then they'll go to hospital.
Absolutely.
My question comes here that in case a vision is lost or reduced, is it possible to regain vision with treatment? When you have given such detailed new modalities for treatment, what are the chances of regaining vision in diabetic retinopathy? If the
So
vision
there
is
are,
lost,
it
yeah.
depends on the stage, Dr. Vashish. So if the patient has come in an early stage where there is just macular edema or retinal swelling, then yes, with injections, we can actually restore the vision as well to normalcy. We have patients going back with 6/6 or 20/20 vision. At the far extreme, I mean, we have a range of conditions or situations they present with. At the far end would be somebody with a chronic tractional retinal detachment, as you call it. And these patients will have macular ischemia, retinal ischemia, where there is absolutely no blood flow to the retinal tissue. So even if we surgically, put the retina back into place, we do the laser, we give the injections, we do everything, there is no function left in that tissue. So this patient is not going to get more than like a half a meter or 1 meter vision, which for a one-eyed patient is still very important. It keeps them ambulatory. So that's the extremes with which they're present. So the earlier they're present, obviously the recovery is much, much positive. The later they're present or with other comorbidities like a bad hypertension where we can't take them for surgery, or very, very high sugars where we can't do an immediate intervention, the prognosis is extremely poor and very often not reversible.
So early identification and
Yes,
early treatment is the actually needed.
absolutely.
Actually.
Absolutely.
Thank you, Dr. Chetra, for covering so well about the diagnosis, the latest diagnostic procedures, and also treatment for diabetic retinopathy. Thank you so much. Now, most of the question I can see here is they are related to Dr. Alok only. So, Dr. Alok, one of the question is how to find diabetic retinopathy with direct retinoscopy and slit lamp examination. Is this possible? This is one of the question asked by Sudarshan Mishra.
Yeah, so thank you. Before I answer that question, I had a comment on how we
Dr.
can
Chetan,
increase the affordability of treatment in diabetes. Now,
Thank
Chetra and we all as retina specialists, we had been treating these diabetic macular edemas, before the anti-VEGF era with subtenons steroids, and then after that, when the preservative free steroids were available, we were giving intravitreal steroid. At least in Chitrakoot, we were using a lot of these, and we were able to get the same kind of wow effect that the anti-VEGFs would give. While there is always a debate which is safer, if we think about cost of treatment, I think steroids scores over VEGF if we take care of the post-operative with IOP spikes or cataract formation in these patients. Because if giving no treatment or is always is worse than offering at least steroid treatment for these patients. And there are advocates of steroid as the first line treatment in patients with diabetic macular edema. So that was one thing that we should be more debating, like whether we should go with what the multinationals want us to give more and more intravitreal anti-VEGFs, or whether we can do with steroids, still do better with steroids. That is one area where we need to debate a lot. Coming back to the question that was, I think, how do we do with direct ophthalmoscopy, screening with direct ophthalmoscopy? And I think that is usually done in most of the general OPDs or physician clinics where they use direct ophthalmoscopy to look for evidence of hard exudates particularly, and that is how the international severity scale classification of staging of diabetic retinopathy was done just to have an easy way of identifying uh, the lesions that are suggestive of diabetic retinopathy in these patients. Of course, it is not a very standard way or a good way of screening patients for diabetic retinopathy, but still you can have a look at the fundus and you can know whether the patient has any retinopathy, no retinopathy or some retinopathy. So that is one thing that you can do with that form of screening. Slit lamp, again, you can use a slit lamp biomicroscope to look at the fundus with dynamic. You can ask the patient to look in all direction and you can actually see for the peripheral retina as well with the slit lamp biomicroscopy. And actually it gives you a better high magnified image of the retina than the indirect ophthalmoscopy. So you can still do it, or you can even use a contact lens if it is available with you to look for diabetic macular edema, which is one of the most sensitive way of looking at diabetic macular edema. So yes, you can identify a diabetic retinopathy using either a direct ophthalmoscope or a slit lamp with a biomicroscope or a contact lens.
Okay, thank you. Hina, can you take 2-3 more minutes? Do you have
Yeah,
some
sure,
time?
sir.
Yeah, sure.
Yeah, sure, sir.
In fact, regarding cost-effective treatment, I would like to give the model which we are using in AIMS. The Avastin injections, we have our own pharmacy and we are dividing that injection into 10 different ampules. And we are providing each ampule for just 1,500 rupees to the patient. So this is one way of achieving cost effectiveness because we have our own pharmacy. So
Yes,
one of the question by Dr. Manisha was that we should use physicians for screening, medical officer for screening. How we can utilize medical officer for screening? What kind of training is required for medical officer if we want to use them for screening for diabetic retinopathy? Dr. Alok.
Yeah, I think most of the physicians, if we talk about, they are trained to look at the fundus. That is what I understand when I was doing my MBBS and I was seeing during my MS examination, most of the residents in the medicines were also being trained for fundus examination using the direct ophthalmoscope. But talking about general physician MBBS, I think uh, rather than going for clinical examination, it would be better if we go for image-based screening, where we do train them or train a technician in their clinic to take good quality fundus imaging. And with the AI now available right left center, you can do a lot of triaging of patients at the physician clinics itself, where you can identify referable, non-referable diabetic retinopathy, those requiring immediate attention and those who can be you can be not an urgent sort of referral is required. So those can be done even at the physician. I think more digital camera image based screening would be possible in the physician's clinic as well as in other non-ophthalmologic centers.
Yes, definitely, Dr. Alok. In fact, we started one program with WHO India where we use this AI-based the fundus camera, and we train nurses, not even ophthalmic technician, the nursing officers at NCD clinic. NCD clinic are there at community health centers in country, and they are now available all over the country. So this is one way of managing that, identifying DR is that an NCD clinic where diabetic patients are being referred and diabetic clinic are being organized. There only we can actually screen for diabetic retinopathy using AI-based fundus camera. When we talk about this AI-based fundus camera, the one question which comes in mind, whether these are available, this AI technology is available free of cost, or we are paying for this thing. Any say about this thing?
There are a lot of things available with cost, without cost. You can actually develop your own. I think most of us are friends with our engineers, and they can develop an AI for you in no time nowadays. So it's not it's not about how expensive it could be. I think when Google came, it was very expensive. And since that, we have had so many AI-based applications, algorithms available. I think even IIT Delhi, which has a very good system for breast cancer detection using AI, They are also planning to do it with diabetic retinopathy, which would be free of cost. And I think yesterday we were discussing that Dr. Rohan Chawla has developed some AI-based app, a phone-based app, which can help. So with the technology will definitely reduce the cost as we evolve. It will reduce the cost, and I think when we started using mobile phones, it was like beyond our pockets. Now it is like everyone is using mobile phones. So that way, technology will certainly be very effective and cost effective in future.
In fact, I would like to mention is that you mentioned about Dr. Rohan Chawla's name. In fact, it is the Ministry of Health and Family Welfare, along with the Wadhwani Group. They have developed this Madhu app. And now, like what we have observed, that we have just validated that the sensitivity and specificity is around 96 and 98% respectively. And our aim is that this app should be available free of cost for use for AI-based screening for everyone in the country. So this is one initiative which has been taken by Government of India, and we hope that this will be available very soon. But I must thank all the speakers that the initiative, this is the first time we have taken this initiative, that beside the talks, we should also have a kind of this moderation where we can have a panel discussion. I believe this is quite effective, that like people will like it, and we may continue it. And our aim for this entire discussion was very clear, that we should identify not only the clinical issues related to diabetes and diabetic retinopathy, but also the public health issue, the advocacy measures required for Government of India, so that we can think of advocacy to Government of India for bringing some policy change in the country. And I thank our team, Hina, the entire Vision 2020 teams, and Roche for supporting this webinar. Thank you very much, all of you. Thank you. Hina, last word from your side. Thank you so
Yeah.
much. Mhm.
Thank you all for attending to this webinar, come panel discussion. We appreciate your time, engagement, and the questions. A special thanks to our speaker, and a special thanks to our moderator, Dr. Praveen Vishisht. And we also thank our corporate advisory board members and Roche for their support. We hope you found the session valuable, and we look forward to seeing you at the future events. Thank you once again. Thank you all.